Hello. In this session, we shall discuss oral surgical management of patients who have been prescribed blood thinners. This session is recorded as a PowerPoint show, which means you should be able to click on each slide and listen to the audio recording associated with each slide. The aims of this session are to provide you with an understanding of drugs which can cause bleeding complications during minor oral surgery, and by the end of the session you should be able to discuss common medications taken by patients undergoing minor oral surgery which may cause complications, specifically bleeding during oral surgery. And we shall be discussing antiplatelet agents and anticoagulant agents in this session. The term blood thinners is used to uh, refer to a group of medications used to prevent and treat vascular thromboembolic disease. And there are a variety of conditions for which these medications are prescribed, including cardiac arrhythmias such as atrial fibrillation, cardiac valvular disease, prosthetic cardiac valves, ischemic cardiac disease such as angina and myocardial infarction, post-myocardial infarction, deep venous thrombosis, pulmonary embolism, and cerebrovascular accident or stroke. Primarily, there are two types of blood thinners: the antiplatelet medications and anticoagulant medications. The antiplatelet medications include aspirin, clopidogrel, dipyridamole, a combination of aspirin and dipyridamole, prasugrel, and ticagrelor. Whilst the anticoagulant medications commonly used include warfarin, dabigatran, rivaroxaban, apixaban, and heparin. And we shall discuss uh, these medications individually during the presentation. You would know from your physiology knowledge that hemostasis is the arrest of bleeding and is classically described in three stages: primary, secondary, and tertiary hemostasis. Primary hemostasis is initiated immediately following blood vessel injury and involves two mechanisms. First is the blood vessel contraction, particularly the arterial vessels. They contract to limit the loss of blood. Simultaneously, uh, there is formation of the platelet plug, uh, which involves adhesion of the platelets to the damaged subendothelial tissues, specifically collagen, um, activation and aggregation. So that leads to the formation of a platelet plug, which causes initial arrest of bleeding. However, it needs to be stabilized through activation of the clotting cascade. So that constitutes secondary hemostasis. Activation of the clotting cascade, which we shall discuss in a bit more detail in the next slides, leads to deposition and stabilization of fibrin, which is the definitive blood clot. Now, at a later stage, to prevent thromboembolic disease, the blood clot undergoes dissolution. So dissolution of the fibrin clot is what we call tertiary hemostasis and is dependent on activation of the plasminogen. This image depicts the uh, mechanisms of hemostasis. Following blood vessel injury, there is a neural response immediately, which leads to blood vessel constriction, reducing the blood flow and reducing the loss of blood. Simultaneously, platelet plug formation takes place and provides initial hemostasis. And this platelet plug is further stabilized through activation of the clotting cascade, which leads to uh, activation and deposition of fibrin, which constitutes the stable hemostatic plug. You would have also learned in your previous sessions that the blood coagulation system consists of a variety of procoagulant and anticoagulant proteins which are normally present in the blood. However, normally the anticoagulants predominate and the blood does not clot, because that would obviously impair the normal flow of blood. This mechanism, whereby there is a delicate balance between the procoagulant and anticoagulant activity in the blood, is part of the homeostasis, which is maintenance of constant internal body environment. So the anticoagulants normally predominate. However, following injury to a blood vessel, external injury, or damage to the internal damage to the cardiovascular system, the blood coagulation system is activated through two pathways. The extrinsic pathway, which is short-lived, is initiated earlier and is related to external injuries to the blood vessels. The extrinsic pathway, following tissue damage, leads to release of tissue factor, which activates factor 7, and then ultimately it leads to activation of factor 10. Similarly, internal damage to the cardiovascular system leads to activation of the intrinsic pathway, which is generally slower to activate but has uh, a longer duration of action. Uh, it leads to activation of various blood coagulation factors, namely factor 12, 11, 9. You don't have to remember all these steps. What you need to remember is that extrinsic pathway is uh, triggered by tissue damage, whereas the intrinsic pathway is triggered by internal damage to the cardiovascular system, and both pathways converge at the activation of factor 10. So that is where the common pathway starts. Uh, so activation of factor 10 leads to activation of prothrombin, which leads to activation of thrombin, and activated thrombin acts on fibrinogen. Now remember, all these blood coagulation factors are normally present in the plasma in an inactive form. So activation of thrombin acts on fibrinogen to convert it into a polymer. Remember, fibrinogen is one of the plasma proteins. So you've got albumins, globulins, and fibrinogen. Fibrinogen is present in the smallest amounts compared to other plasma proteins. So once fibrinogen is activated, it polymerizes to form the fibrin polymer, which is a cross-linked form of fibrin, and that is what a blood clot is composed of. So remember these pathways, because we shall be referring to these when we discuss various blood thinners. The first category of blood thinners you need to be aware of are antiplatelet medications. So 5 antiplatelet agents are commonly prescribed to the patients. Aspirin, which causes irreversible inhibition of the cyclooxygenase pathway. So you would remember from your knowledge on the arachidonic acid uh, metabolism during inflammation and release of chemical mediators of inflammation, that the phospholipid bilayer uh, of cell membrane stores arachidonic acid, and it can be metabolized via two main pathways, the cyclooxygenase pathway and the lipooxygenase pathway. So aspirin is one of the non-steroidal anti-inflammatory drugs which causes irreversible inhibition of the cyclooxygenase pathway and prevents synthesis of thromboxane A2, which has procoagulant properties. So by virtue of this, aspirin inhibits uh, activation of platelets and reduces the procoagulant activity in the blood. Mind you, aspirin is also used as an analgesic, but the dose is around 300 milligrams, whereas aspirin used as an antiplatelet medication is a low dose aspirin, 75 milligram. Dipyridamole is a reversible antiplatelet medication. It also inhibits thromboxane A2 like aspirin, but also stimulates prostacyclin, which has uh, antiplatelet properties. Clopidogrel, again prescribed as a 75 milligram tablet, causes irreversible inhibition of ADP receptors on platelets, thereby preventing their activation. There are two other antiplatelet medications, prasugrel, which causes irreversible inhibition of platelet aggregation, and ticagrelor, which causes reversible blockade of ADP receptors on platelets. Now remember, aspirin, clopidogrel, and prasugrel are irreversible inhibitors of platelets, whereas dipyridamole and ticagrelor are reversible inhibitors of platelets. And also remember, the normal lifespan of platelets is 8 to 12 days, and we'll come back to this at a later stage. The full guidance on management of patients on antiplatelet medications is accessible from this link on the PDSC website, and I would advise you to read this guidance thoroughly so that when you see patients on antiplatelet medications who require tooth extractions on clinic, you are able to prepare and manage them appropriately. The second group of blood thinners are the anticoagulant medications, which impair one or more steps in the coagulation cascade, and these drugs include warfarin, dabigatran, rivaroxaban, apixaban, and heparin, and we shall discuss each one of them in a bit more detail in the next slides. But again, I would urge you to read this guidance on the PDSC website on the management of patients on anticoagulant medications, and you will see a fair number of patients who are prescribed these medications. So you need to read this guidance in order to be able to carry out tooth extractions on patients who are prescribed anticoagulant medications. Regarding anticoagulant medications, warfarin is the most common agent, uh, anticoagulant agent, which has been used for the last 50 years, and there are approximately a million users in the UK. In addition to warfarin, NICE has approved some other anticoagulant medications for the management of atrial fibrillation, which is one of the most common form of cardiac arrhythmia, and the incidence is around 0.5% in patients 50 to 59 years old, and as high as 9% in patients 80 to 89 years old. So the use of newer anticoagulants such as dabigatran, rivaroxaban, and apixaban is likely to increase due to aging population in the UK. So the first medication we are going to discuss is warfarin. Warfarin acts by causing inhibition of factor 2, 7, 9, and 10, plus protein C and protein S to a lesser degree. So these factors are basically vitamin K dependent factors which require vitamin K for their synthesis in the liver. The effective half-life of warfarin is 20 to 60 hours, mean is 40 hours, and obviously because these are vitamin K dependent factors, the main antidote for warfarin is vitamin K itself. What you need to remember is some of the important drug interactions. So some of the drugs you may prescribe as a dentist or dental therapist through your dentist have interactions with warfarin, which you need to remember. Uh, some drugs cause enhanced action of warfarin, that is increased anticoagulation. These include azole and antifungals, so drugs such as miconazole, fluconazole, which are frequently prescribed for candidiasis, ketoconazole, and to a lesser extent, itraconazole. They can all enhance anticoagulant activity of warfarin. Similarly, some of the antibiotics prescribed in dental practice, erythromycin, clarithromycin, metronidazole, azithromycin, tetracycline, doxycycline, cephalosporins, and levofloxacin, they can all enhance anticoagulant activity of warfarin. Common analgesics such as non-steroidal anti-inflammatory drugs, including antiplatelet agents such as aspirin, clopidogrel, and ibuprofen, will also enhance anticoagulant activity of warfarin. So the thing to remember is that if patients are on warfarin, it is best to avoid these three groups of drugs because they may increase anticoagulant activity of warfarin, increasing the risk of bleeding and cerebral hemorrhage. Uh, Certain foods and herbs, such as cranberry juice, garlic, alcohol, dietary supplements, may also have an impact on increasing the anticoagulant activity of warfarin. On the other hand, uh, green leafy vegetables, which are rich in vitamin K, vitamin E supplements, will decrease the anticoagulant activity of warfarin. So you must remember these medications so that when you see patients who are on warfarin and when you're planning their management, you're aware of these drugs. So you avoid these drugs uh, as analgesics, antibiotics, or antifungals to minimize the risk of bleeding. In any case, you should always refer to the BNF when prescribing medications to patients. Warfarin is available as tablets, which are color coded depending on their dose, so that patients can easily recognize them because sometimes they may be prescribed more than one strength of warfarin. Uh, so it's available as a 5 milligram tablet, 3 milligrams, 1 milligram, or zero point 0.5 milligram, and they are of different colors for uh, quick recognition. Warfarin mainly targets the extrinsic and common pathways of blood coagulation, and its activity needs to be monitored closely to avoid overdose and risk of increased bleeding. Warfarin activity can be monitored by measuring the prothrombin time of the patient. However, the reagent which is used to measure the prothrombin time, that is thromboplastin, uh, the results can vary depending upon uh, how prothrombin has been manufactured. So therefore, in order to standardize the prothrombin time, uh, the international normalized ratio or INR test has been developed, which is basically uh, patient's prothrombin time compared to a control. So that gives you a ratio. So obviously in a fit and healthy patient who is not on any medication, their INR would be 1. Whereas patients who are at risk of cardiovascular disease, such as patients with prosthetic heart valves or patients with a history of valvular heart disease, ischemic heart disease, thromboembolic disease, or uh, cerebrovascular accidents, that is stroke, their INR is usually kept between 2 to 3.5. So their blood is kept much thinner to reduce the risk of cardiovascular events. And so therefore, INR is the main test which is used to monitor the activity of warfarin, and it can be done in the laboratory or using uh, prothrombin INR monitors, which are very similar to glucometers. Um, and you would see that patients on warfarin carry uh, a booklet known as the Yellow Book, which gives results of their warfarin over the last few months so that their response to warfarin can be monitored. So when patients on warfarin, they require tooth extractions, you must ask them about their Yellow Book so you can quickly browse to see that their results are consistent over the last few months, and you can prepare them appropriately for the tooth extractions. So when you see patients on warfarin who require tooth extractions or other oral surgical procedures, what you need to do is to establish patients' INR over the last 2 months. So have a look at their INR card or Yellow Book, which will give you an idea how well controlled their INR has been over the last few months. And then you would request a fresh INR on the day of the procedure through the patient's GP. So the patients could go to their GP first thing in the morning, get their INR test done, and bring the results to you on clinic so that you can carry out their tooth extractions or other surgical procedures as long as their value is within a normal range. Uh, Ideally, as I said, INR should be measured on the day of the procedure, but if this is not possible, results from the last 72 hours can be acceptable. However, INR done uh, more than 72 hours ago uh, will not be valid, and you would need a fresh INR test. The national guidance in the UK is that if the patient's INR is less than 4, they can have minor oral surgical procedures done in primary care. So up to 3 extractions can be done in primary care if the INR is less than 4. However, as an additional safety measure in the dental education facilities, we would accept values up to 3.5 for extractions done by students or other surgical procedures done by students. If the INR is over 4, non-acute cases can be referred back to the GP to adjust the dosage of warfarin and get their INR below 4. However, if patients require urgent treatment, they can be referred to secondary care. But obviously, uh, in such cases, you would need to call up the MaxFax at the local hospital if it's urgent. And we've already discussed the antidote for warfarin, if you remember. That's vitamin K, just to remind you. That can be used to uh, counter the effects of overdosage of warfarin or increased risk of bleeding during the surgical procedures, but is not normally required. Next, we shall discuss 3 anticoagulant drugs which are recommended by NICE for the management of atrial fibrillation. These include dabigatran, rivaroxaban, and apixaban. Uh, Dabigatran uh, exerts its anticoagulant activity by binding reversibly to thrombin, uh, thereby preventing its activation. So you would know from your knowledge of the clotting cascade that if thrombin activation is impaired, it would no longer be able to activate fibrinogen in the blood plasma, thereby preventing the conversion of fibrinogen into fibrin polymer or the blood clot. So that's how dabigatran exerts its anticoagulant activity. The half-life is 12 to 17 hours, and it is prescribed orally in a dose of 150 milligram twice daily. An antidote for dabigatran has been developed recently, which is idarucizumab or Praxbind. However, it is an extremely expensive drug, can only be administered in hospital settings, and only used sparingly. Because dabigatran mainly affects activation of thrombin, uh, the prothrombin time or INR uh, tests are not the right ones to monitor the anticoagulant activity of dabigatran, and it is mainly monitored either using APTT, which measures the integrity of intrinsic and common pathways of blood coagulation, or by measuring the thrombin time. These are hospital-based tests, and you would normally not be able to request them through the patient's GP. And we'll discuss the implications when we discuss the overall management, oral surgical management of patients on uh, antiplatelet and anticoagulant medications. Rivaroxaban is a reversible inhibitor of factor 10, so that's where both the intrinsic and common pathways converge. Uh, it is available as the commercial preparation is Xarelto. Half-life of 5 to 7 hours in adults, prolonged to 12 hours in patients over 75. Standard dose 20 milligram tablets once daily, and Again, there is an antidote available, Adexanet alpha. However, just like uh, idarucizumab, it's only administered in hospital settings. Again, little or no effect on prothrombin time. So INR again is not the right test, and it's measured either by APTT or anti-factor 10 assay. So that's how you monitor the activity of rivaroxaban. Apixaban is very similar to rivaroxaban and is a reversible inhibitor of factor 10A. Half-life 12 years, standard dose 5 mg twice daily. And again, the antidote is similar, Adexanet, little or no effect on prothrombin time. So INR is not the right test, and again measured using activity monitored using APTT or anti-factor 10 assay. So the thing to remember is that if your patient is on Warfarin, you can request the INR through their GP, whilst for the other three drugs, dabigatran, rivaroxaban, and apixaban, even though hospital-based laboratory tests are available for monitoring their anticoagulant activity, these are not normally requested when carrying out minor oral surgical procedures. As we discussed with warfarin, you need to be aware of the drugs which are contraindicated in patients using these three anticoagulants. So patients on dabigatran, obviously they don't need any other anticoagulants, uh, azole-based antifungals, just like warfarin, um, miconazole, fluconazole, etc. And then some other drugs which you would not be uh, prescribing normally, so you don't need to worry. But in any case, if your patient is on uh, any anticoagulant or antiplatelet medication, or for that matter, whenever you are prescribing any medication such as analgesics or antibiotics or antifungals, you must look up the drug interactions with any of the medications the patient is already taking. For rivaroxaban, again, other anticoagulants are contraindicated because that would lead to potentiation of anticoagulant activity and will increase the risk of bleeding, and azole antimycotics or azole antifungals. Obviously, you're not going to prescribe HIV protease inhibitors, so you're not primarily responsible for this, but you should focus on the drugs which you can prescribe in dental practice settings as a dentist, or you may request your dentist to prescribe as a therapist. Apixaban, again, very similar. Other anticoagulants and azole antifungals are contraindicated. And then you also need to be aware of medications which may increase the anticoagulant activity of dabigatran, rivaroxaban, and apixaban, and mainly the drugs which can increase the activity of these drugs, which you would prescribe as a dentist, include aspirin, non-steroidal anti-inflammatory drugs, and clopidogrel. And these are common to all three drugs. And you can read about other medications as well. Uh, the anticoagulant effect of dabigatran, rivaroxaban, and apixaban is decreased by phenytoin, carbamazepine, which are both anti-epileptic drugs, and carbamazepine is also used for trigeminal neuralgia, rifampicin, which is uh, an anti-tuberculous drug, but obviously you're not going to be prescribing these drugs, but you just need to be aware of these. Finally, we shall discuss heparin, which is another anticoagulant drug. Although you are unlikely to come across patients who have been prescribed heparin in practice, but you still need to be aware of this medication. Heparin, as you would know, is a natural product found in mast cells that line the vasculature. So mast cells are basically basophils lining the blood vessels, and heparin from mast cells is released in response to injury or during allergic reactions. It exerts its anticoagulant activity through a variety of mechanisms. Firstly, it binds to antithrombin 3 and prevents conversion of prothrombin to thrombin, which obviously is essential for the subsequent steps. It also inhibits activation of factor 10. And finally, there is some evidence that it also prevents the conversion of fibrinogen into fibrin. So it has a multimodal action uh, in terms of its anticoagulant activity. The antidote for heparin is protamine sulfate, which you may be intrigued was initially extracted from the sperm of fish. However, now synthetic forms are available. Heparin is normally administered parenterally through subcutaneous route, uh, and the main clinical indications for heparin are acute thromboembolic episodes, prolonged or major surgical procedures to prevent deep venous thrombosis and pulmonary emboli, and it can also be prescribed short term for management of acute ischemic heart disease. Having gained an understanding of the pharmacology and monitoring of blood thinners, um, we shall now come to the main topic, which is oral surgical management of patients on antiplatelet and anticoagulant medications. So patients who are on antiplatelet therapy, their drugs should not be stopped prior to the dental surgical procedures. If the patients are on monotherapy, that is, they are taking one of the antiplatelet agents such as aspirin, clopidogrel, ticagrelor, etc., or even if they are on dual therapy, that is, they are taking two antiplatelet agents together, their drugs should not be stopped. And the reasons for that are twofold. Firstly, stopping these drugs 1 or 2 days prior to the surgery is not going to be beneficial because these drugs, their effects last for a good 7-8 days, so it's not going to significantly reduce the risk of bleeding. Secondly, stopping these drugs increases the risk of cardiovascular events in these patients, and it is best to uh, for these patients to continue on their medications, uh, and bleeding can be controlled using local measures, which we shall discuss in the next slides. However, if the patient is on triple therapy, which is quite rare, that is, they are taking three antiplatelet agents together, if they are a particularly high risk case for thromboembolic events or cardiovascular events, then you can consult the patient's cardiologist or GP to see if one of these drugs can be stopped. Uh, However, if this is not possible, you can always refer the patient to secondary care. For patients on anticoagulant medications, oral surgical management protocols are based on national and NICE guidelines. So generally speaking, patients on warfarin or other anticoagulant drugs such as dabigatran, rivaroxaban, or apixaban, their medications should not be stopped, and minor oral surgical procedures can be done safely in primary care using additional hemostatic measures, which we shall discuss shortly. Um, Obviously, for warfarin, you would want their fresh INR ideally on the day of the surgery. However, tests done in the last 72 hours are acceptable. For other drugs, dabigatran, rivaroxaban, and apixaban, normally you would not request any laboratory tests, and you can carry out minor oral surgical procedures without stopping these drugs. However, for drugs which are prescribed 12-hourly, such as dabigatran or apixaban, the morning dose of the medication can be stopped and patients can resume their normal medication regime after the surgery. Whenever in doubt, you can always liaise with the patient's GP for consultation and advice. As discussed previously, you are quite unlikely to see patients who are on heparin in primary care settings. Again, generally, there is no need to interfere with heparin or low molecular weight heparins like Clexane, but you can always liaise with the patient's GP to ensure that the patients are not at high risk of bleeding. Uh, and again, you can use local measures to control bleeding. A gap of 6 to 8 hours before the last dose of heparin is preferable for minor oral surgery, although not essential. Having established that for most patients on antiplatelet and anticoagulant medications, you are not going to stop their drugs prior to minor oral surgical procedures. Obviously, for warfarin, you would want a fresh INR, and you can miss the morning dose for uh, dabigatran and apixaban when prescribed 12-hourly. The management of patients on blood thinners should take into account the type of surgical procedure, the underlying condition for anticoagulation. Obviously, if they have underlying cardiovascular disease, that has implications on invasive dental procedures. You should identify additional risk factors, and INR value is only for warfarin. Uh, Ideally, you should schedule surgical procedures in the morning so that if patients experience post-operative bleeding, they can be seen at the dental education facilities in the afternoon. And it's best to avoid Fridays because obviously the dental education facilities are closed over the weekend and patients may struggle to get emergency help. You must warn the patients of risks of intra and post-operative bleeding and bruising. And like in any patient, preventive care is essential so that the need for invasive surgical procedures can be minimized. So patients who are on antiplatelet or anticoagulant agents can have minor oral surgical procedures done in primary care. So simple extraction of up to 3 teeth can be done in a single appointment. Obviously, you're not going to extract all 3 teeth back to back, so you would extract one tooth first, establish hemostasis before you move on to the next tooth, just to be on the safe side. You can also do one minor oral surgical procedure, such as removal of a lump or bump uh, or a biopsy. Similarly, one course of periodontal scaling and root debridement can be done in primary care. You should use LA with vasoconstrictor because it's going to limit the amount of bleeding, but you should administer LA using infiltration or intraligamentary injections, and you might find that Articaine can be quite handy because you will be able to avoid nerve blocks, and you can do most restorative procedures with infiltrations alone, even in the mandibular, molar, premolar region where you would normally administer a nerve block. So Articaine is quite useful. Uh, you would obviously minimize surgical trauma in any patient and every patient, but obviously you need to be a bit more careful in patients who are on blood thinners. In addition to the precautions already discussed in terms of preparing and scheduling the appointments for patients on blood thinners, one of the key additional hemostatic measure is to pack the extraction sockets with Surgicel or gel form, which are artificial uh, dressings to aid hemostasis. So they help in blood coagulation. And then you would want to place a suture across the extraction socket. Ideally, you should, following packing of the surgical dressing, as you can see in this slide, you should place a horizontal mattress suture across the extraction socket. And if you've done more than one extraction, you would place one horizontal mattress suture across each extraction socket. So this is the standard uh, horizontal mattress suture. You don't aim to close over the socket because that would not be possible, but the suture would allow compression of the gingivae against the alveolar bone and aid hemostasis, and it would also help to retain the surgical dressing to aid hemostasis in the socket. Another type of horizontal mattress suture is a figure of 8 suture, which goes like a crisscross over the extraction socket, but although it's going to uh, reduce the risk of dislodgement of the uh, surgical dressing more so than the standard horizontal mattress suture, the figure of 8 suture is associated with increased entrapment of debris. So it's not necessarily essential in every case. You will get training on different types of sutures, suture materials, and hemostatic agents in a separate plenary later in your program. But for now, you should just remember that when we say additional local hemostatic measures, what we mean by that is A, use of a vasoconstrictor in your LA, and B, placement of a surgical dressing to aid hemostasis. Two of those are available in the dental education facilities, Surgicel and gel foam, and C, placement of a horizontal mattress suture across the extraction socket, either a standard horizontal mattress or a figure of 8 horizontal mattress suture. Lastly, but very importantly, you must ensure that patients who are on blood thinners, you achieve hemostasis in the surgery before discharging your patients. You would obviously do that for every patient anyway who undergoes tooth extractions or surgical procedures, but obviously you have to be extra cautious in patients who are on antiplatelet or anticoagulant agents. And what you also want to remember is that patients who are on antiplatelet agents, because these drugs primarily inhibit platelet plug formation and do not have an effect on the coagulation cascade, what you would find is that patients on antiplatelet agents would initially show increased bleeding, but once with local measures, a platelet plug has been formed and further stabilized with a blood clot. These patients are less likely to bleed post-operatively following discharge from your care. On the other hand, patients who are on anticoagulant medications, they might initially show hemostasis due to formation of a platelet plug, which can be quite deceptive because the platelet plug, as you know, needs to be stabilized further with a fibrin clot. So whilst they may stop bleeding initially, they are much more likely to bleed post-operatively by the time they get home, because if the blood clot does not form and stabilize, bleeding would start again. So you have to be a bit more careful with patients on anticoagulant agents, that you make them sit in the surgery and observe them for longer before you discharge them with the post-operative advice. So make sure you provide post-operative instruction sheet specifically designed for patients taking anticoagulant or antiplatelet medications. In terms of analgesia, you would have figured out by now that you do not want to prescribe non-steroidal anti-inflammatory agents such as aspirin or ibuprofen for pain control, because these can increase the anticoagulant activity of other drugs, and therefore you want to prescribe something like paracetamol, which is a lot safer in patients on antiplatelet or anticoagulant agents who undergo oral surgery. The other option would be dihydrocodeine phosphate, but paracetamol is usually adequate for most patients. And also make sure that you do not prescribe antibiotics or antifungal agents which may interfere with uh, antiplatelet or anticoagulant agents the patient is taking. And then you can finally organize a follow-up appointment, make sure they have emergency contact details should the bleeding restart, and make sure this has been discussed with the patient before you discharge them. So, a few points to summarize the session. You must identify medications which may increase the risk of bleeding in oral surgery intraoperatively or postoperatively. These medications might have been prescribed to your patients by their GP or cardiologist. The two main groups are antiplatelet and anticoagulant medications. And if they have been prescribed these medications, you must prepare and manage your patients appropriately. So all the precautions regarding not stopping the medications, INR for Warfarin, scheduling the appointments early morning, avoiding Fridays, use of LA with vasoconstrictor, primarily with infiltrations and intraligamentary injections, and avoiding nerve blocks, use of additional hemostatic measures such as artificial coagulant dressings, gel foam and Surgicel, and placement of horizontal mattress sutures across the surgical site are the key things. Whenever you are in doubt, don't be shy to liaise with the patient's GP or cardiologist. And if these patients are not suitable for uh, treatment in primary care and require urgent treatment, you can always refer them to the local maxillofacial department over the telephone. Whenever in doubt, you should refer these patients. So with regards to further reading, I've already highlighted the PDSC guidelines on surgical management of patients on antiplatelet and anticoagulant agents. The links have been provided in the presentation, and you can always uh, click on the PDSC website and download these guidelines. Uh, they've been updated quite recently, and you would find that they are tailored to your working pattern in the dental education facilities. In addition, you can also look at the ST-CEP guidelines, management of dental patients taking anticoagulants and antiplatelet drugs, which are available on the ST-CEP website.